Okay, so we're going to touch on some of the highlights. Hard to do all of this due credit within 30 minutes, but we're going to touch on some of the highlights and a few of the controversies involving the major vessels in the chest. Let's start with the appearance of aneurysms. Karen talked about the appearance of aneurysms versus pseudoaneurysms in the heart. And there's a few differences between the heart and the aorta. In the aorta, it's predominantly about shape, right? Fusiform aneurysms are usually true aneurysms with they don't really have a neck on them. They're just a focal dilation, whereas pseudoaneurysms are saccular. Whereas in the heart, it often involves the neck itself and the location, not so much the shape as much. So that's an important point to start with. True aneurysms are fusiform, pseudoaneurysms are saccular. So what size do we consider abnormal in the chest? And there's a large study that looked at non-contrast CTs and normal sizes, and what they found was the average size, obviously, of the descending is quite a bit less than the ascending, and dilation is considered 2 standard deviations above the mean. That's abnormal. So an abnormally enlarged ascending aorta is around 4 centimeters or above, and an abnormally large descending aorta is around 3 centimeters or above. The size of an aneurysm is approximately 1.5 times the mean. So you can see aneurysms are considered about 5 in the ascending and about a little bit over 3.5 in the descending. Now, we'll see in the next slide, and I'm going to come back to this slide in a second, this is a chart of the risk of rupture, which is perhaps the most important thing to know because we want to know when we need to intervene and do surgery. So we want to know when that risk of rupture goes up from a low baseline of around 5% or less and starts to go significantly up. And you can see that for the ascending aorta, that happens at around 6 centimeters. Above 6, the risk of rupture goes up to about 35%. Below 6, it's somewhere in the range of around 5%. And the descending, that threshold's around 7 centimeters. So let's go back to this slide for 1 second. So the ascending aorta is at a baseline larger, right? But that being said, it ruptures at a lower level. So what we tend to use for these numbers are just, we remember 4 and 5 for both ascending and descending, even though that's not exactly correct because we use those numbers because the risk of rupture over descending is at a higher threshold, okay? These are perhaps the most important numbers. So when surgeons intervene on aorta, they tend to intervene a bit before this occurs, this significant increase in the risk of rupture. So ascending would be around 5.5, descending would be around 6.5. And of course, we can see signs of impending rupture or of rupture on a CT scan, and those, other than just size, those are also perhaps really, obviously those are exceedingly important to know about. This is an initial CT in a patient who had an aneurysm that was pretty close to 6.5, 7 centimeters. So it was in the range where we probably would have repaired even this descending aorta. Patient comes back with acute symptoms, has some periaortic soft tissue, which when you put Hounsfield unit measurements on that was in the range of about 40, 55, so in the range of blood. And you can see this little finger-like projection, which you usually associate with a penetrating ulcer, but in this case was a localized site of rupture that was relatively contained, but only with a little bit of periaortic hematoma. So what are the other signs that we look for? One is for impending rupture. One is the aorta itself looks abnormal. It has a weird shape. It's not nice and round or oval. And in the abdomen, we don't really see this in the chest very much, but in the abdomen, that's the draped aorta sign, where the aorta loses its continuity and sort of drapes over the spine. Sometimes we see bands of high attenuation or large areas of high attenuation within areas of atherosclerosis, which are usually lower density. That is a potential sign of impending rupture. Obviously, changes over time. If it increases quickly in size or changes shape, over time, that indicates it's perhaps losing its continuity and starting to lose its ability to maintain blood flow. And then anything outside or around the aorta, like hematoma, obviously extravasation of contrast. Sometimes you just see stranding or lung consolidation adjacent to an aortic aneurysm, which all are indications of potential or impending rupture. Here's one example of the high-density atherosclerosis. You can see on the contrast portion of this examination exactly where the unopacified and the opacified lumen, the difference between the two. And within this area of atherosclerosis, it has this very high density, again, in the range of about 60 Hounsfield units. So this is a sign of potentially of impending rupture. Okay, so that's aortic aneurysms and aortic rupture or impending rupture. So what is this? You have this dilated aorta, descending aorta here. but you can see that there's this sort of focal saccular outpouching. We see where the lumen should be, right? There's the calcification. We expect the lumen to be there. So there's this focal saccular outpouching with a narrow neck that looks like a pseudoaneurysm. And there are multiple causes of pseudoaneurysms where not all three layers of the wall are present. Trauma, some sort of iatrogenic injury, surgical things like that. Penetrating ulcer can cause pseudoaneurysms. And then this one, this is actually a mycotic pseudoaneurysm. Patient was an intravenous drug user and had actually had both septic emboli and had more embolic phenomenon to more of the systemic arteries as well. And we call these mycotic aneurysms, not because it's usually due to fungus, it's usually due to staph, salmonella, or bacterial organisms. We call these mycotic aneurysms or pseudoaneurysms because they look like a mushroom, doesn't it? It looks exactly like a mushroom here. Okay, the one exception to the focal saccular outpouching being a pseudoaneurysm in the aorta is this, which is the ductus aneurysm. You can see there is a focal saccular outpouching here, but it's in a very classic location. It's the underside of the aortic arch. And on this oblique sagittal view, you can see there's actually a little band of fibrous tissue that connects the underside of the aortic arch and that little aneurysm to the main pulmonary artery. This is the one exception to saccular aneurysms equal pseudoaneurysms. This is the ductus aneurysm. And we know it's this because it's in its typical location. Of course, you can make the argument that trauma commonly occurs here too, but usually you can tell the difference by history. Okay, so that's aneurysms, pseudoaneurysms. Let's briefly talk about intramural hematoma and dissection. Many people don't realize that these are thought to be, when due to hypertension, which is the most common cause of both of these, are thought to be within the same spectrum. They have a spectrum of disease. And here's an example of a type A intramural hematoma. We see this thickening of the wall of the ascending aorta. So I always say ascending aorta because our power scribe doesn't pick up ascending. So I'm like ingrained to say ascending, which is a little bit, nefarious. Anyway, so you see this high density thickening of the ascending aorta, and the non-contrast is very helpful because you can see it's high density as opposed to atherosclerosis or vasculitis, which should be lower density. And again, these intramural hematoma and dissection are thought to be a spectrum of the same disease when due to pulmonary hypertension. And the first insult is you get some bleeding of the vasa vasorum that supplies the wall, and that bleeding causes weakening of the wall, and then because of the high shear forces within the aorta, because of hypertension, that eventually may lead to a defect. And you can see these are often seen in association, or one may lead to the other. This is an example of an intramural hematoma that over 2 months, the patient was not treated appropriately, turned into a dissection. So spectrum of the same disease when due to hypertension in particular. Non-contrast, this is one of the main uses of non-contrast CT, why we get it routinely in patients with a suspected acute aortic syndrome. Both of these cases on the post-contrast CT, so the wall is thick, and I would ask you, is that due to atherosclerosis? Does the patient have some sort of vasculitis, like giant cell arteritis? A little bit hard to tell. But on the pre-contrast CT, you see both of those show crescentic high density within the wall, blood density, and that confirms without any doubt that this is intramural hematoma as opposed to one of those alternatives. So not only is it important for us as radiologists to detect intramural hematoma, we need to give some other information because surgeons over time have become less aggressive about doing surgery in patients with type A intramural hematoma. Not type A dissection, but type A intramural hematoma. So there are other important things for us to mention in a report. And there's a whole bunch of data on this. This is sort of some of the more conservative numbers. So one thing to mention is the thickness of the intramural hematoma. When it's above 10 millimeters, 10 or millimeters or greater, they tend to be more aggressive about surgery. When it's below that, they tend to be more conservative and do medical management and hope that it resolves. Overall size of the aorta, more than 4 centimeters. And then intramural hematoma can be from other etiologies. It's most commonly from hypertension, but it can be from other things like penetrating ulcers, and those are less likely to resolve on their own. So when it's due to that, the surgeons are more aggressive about doing surgery on type A intramural hematomas. This you all know, at UCSF we have a little competition with Stanford, and we begrudgingly use their classification schemes, but it's relatively simple, so okay, we'll use that, that's fine. The DeBakey, that's 3 things, I don't want to remember 3 things. I can only remember a limited number of things. So what are the important things for us to mention in a radiology report about dissection? One is obviously the maximum size. The bigger the aorta is, the more likely the surgeon is going to be patient's going to be going to surgery in type B dissection. The majority of type A dissections will go regardless of size, but overall maximum size is important. Any periaortic hematoma, obviously, because we've seen that with the aneurysms, that has a higher risk of rupture. You identify the true versus the false lumen, and then you see which vessels originate from the false in particular, because the false lumen shows slow flow. Those vessels, the organs that are supplied by those vessels, have a much higher risk of end organ ischemia when they originate from the false lumen. That includes the renal arteries in particular are a good example of that. But of course, any of the takeoff of the great vessels that lead to the carotids, things like that, are very important to identify their origin. And then there are some other complications. One of the most common ones is pericardial hematoma, which is clearly a bad complication that needs some emergent surgery. So these are some of the things that you should include in a radiology report when you detect a dissection. Here's one example of a dissection with all of this soft tissue in the mediastinum surrounding it. It was measuring blood density. So this is technically a type B dissection, but because of this periaortic hematoma, the patient went to surgery because there was a concern that there was some contained rupture in this, associated with this. What about these sort of variants of atherosclerosis? And these are the ones we talk about, these sort of inflammatory variants of atherosclerosis. Ulcerated plaque and penetrating ulcer. We can see here's normal aorta on the top left, atherosclerosis, and then ulcerated plaque is sort of an inflammatory subtype of atherosclerosis where you get a little crater that extends into the atherosclerosis, but intima overlies that entire crater. Whereas in a penetrating ulcer, the intima is violated, and that crater extends deeper and deeper into the media, and when you have exposed media, it weakens the wall and bad things happen. So you often develop complications in that setting of penetrating ulcer. So the question is, how do you distinguish ulcerated plaque from penetrating ulcer? Well, here's a sort of big blown up version of that, and you can see the difference again is the fact that the white is the intima. In the penetrating ulcer, there is exposed intima, and that ulceration extends deeper into the media. And that usually causes problems. And the main problem that causes is the wall gets weak and starts to bulge outwards. That's really the main way in radiology we distinguish ulcerated plaque from penetrating ulcers. What's that external contour of the aorta like? Is it bulged out? In which case we could call it a pseudoaneurysm, right? A little pseudoaneurysm, or is it not? This is an example of extensive ulcerated plaque, which is it's not going to be a problem per se, but it can be associated with embolic events to various, systemic arterial structures, or various structures supplied by the systemic arteries. You can see these little craters, but when you look at the external contour of the aorta on the sagittal view, you can see that there's not really a focal bulge where you see that contrast extending into the atherosclerosis. Whereas if it was a penetrating ulcer, we would expect this to be bulged out. Here is a penetrating ulcer, and you can see very clearly this sort of contrast extending into atherosclerosis, and on the coronal image you can see how there's a very focal saccular outpouching. This is a little pseudoaneurysm related to a penetrating ulcer because the wall is weakened, because there is missing intima and media there. It weakens the wall. Some of the most common complications of penetrating ulcer are, well, when contrast starts to extend into the wall, it can bleed into the wall and you can get intramural hematoma. That also may lead to more frank dissection when blood starts to dissect up and down from that site of entrance into the wall. Obviously, this is probably the most common complication we see. This is a penetrating ulcer that has caused a little pseudoaneurysm because the wall is focally weak there. And then obviously gross rupture. Last time I checked, I see 4 little dots of contrast here, and last time I checked, there's only 3 takeoff of the great artery. So this is a focal area of contained rupture. All right, great. Briefly on coronary arteries, I'm not going to spend a lot of time on coronary arteries, but I'm going to touch on this thing because I think a lot of this is not really super well understood. And so here's a patient presenting with chest pain. And we do coronary CT to look for, most commonly to look for atherosclerotic disease and obstructing lesions. But occasionally we see this. So here we have a coronary artery, which looks like, if I get my mouse up, looks like it's coming off the wrong spot, right? Here's the left, This actually turns out to be the right that's coming off in a weird location. So here, let me draw, this is an anomalous coronary, and it's important to know all the different subtypes of anomalous coronary because some of those are associated with risk of sudden death and others are not. So there's the aorta, there's the pulmonary artery, sorry, the right ventricular outflow tract. The left normally originates, or the right normally originates very anteriorly and extends right directly into the atrioventricular groove. The left originates more posterolaterally. Okay, so those are the normal origins. So we're talking about, this is an example of the right coming off next to the left, from the left sinus of Valsalva. And there's a few ways that can get back to where it needs to go. One of those ways is in front of the right ventricular outflow tract. The other one of those ways is behind the aorta. Actually, it's very unusual for the right to do this. Usually it's the left that does that, and we'll show you one example of that. But this is called the retroaortic course. And then it may extend between the two, and this is the bad one. This is the one that can be associated with arrhythmias and sudden death, and this is the one that really wants to be evaluated further. We call that intramural or interarterial, okay? And this is one example of that. This is a patient with an anomalous right coronary that is interarterial, and we have to worry about this lesion. But I'll show you a little in a second some of the data behind that. Here's the curved multiplanar reformat just laying out the entire right coronary, and as is typical of an interarterial course, it is also intramural, which means at that point by the arrow is traveling within the media, within the wall of the aorta over a fairly long segment. And that's what's thought to cause the problem. When it's traveling in the wall of the aorta, that course is long, that can cause narrowing and can cause ischemia and arrhythmias, particularly with exercise and things like that. Here's another one of those variants. This isn't a variant, this is a variant that's important to know, but is not going to cause symptoms per se. All right, so this is someone who has, there is the right coronary artery traveling in the atrioventricular groove, and then there's this extra vessel, you can see the red arrow there, that kind of extends around the aorta, posterior and inferior to the aorta, and eventually when we follow it, it runs into the interventricular groove in this location right down in here. And I'm going to show you a curved multiplanar reformat of that, or a oblique MIP of that. And what you see is that's the right, and this is the left that comes off next to the right coronary artery from the right sinus of Valsalva, travels behind the aorta, and eventually goes to where it should go. So again, this is really important to know because on cath, they have a very difficult time telling, is this one of those variants that's associated with sudden death, or is this one of those variants that's not usually associated with any problem? That's the case in this case. On cath, it's hard for them to tell. CT is considered the gold standard for this. This is one reason I talk about this, because often after cath, they'll get a CT to evaluate for the course and the location. This is not one of those bad actors. Here's another one that's not one of those bad actors. You have a anomalous left that's running in front of the pulmonary artery and the right ventricular outflow tract. Now, it's nice to know before the person has a CABG and they do a sternotomy and cut right through this thing. It's nice to know ahead of time, but this is not going to be associated with sudden death and arrhythmias by itself. Okay? Okay. This is not an uncommon phenomenon. We see this relatively frequently as an incidental finding or in patients with symptoms of chest pain and potential arrhythmias and things like that. The right coronary anomalous right coronaries are much more common than left. The patients who are at higher risk are patients who exercise severely. But interestingly, this is a large study looking at a bunch of young military recruits who died of sudden death, and they found that there were about 130 non-traumatic deaths. 21 of those were anomalous left, and 0 were anomalous rights. So in fact, we always debate about the significance of the anomalous right when it's interarterial. And if the CT is the only finding, it's important to mention it. But if there is no other evidence of chest pain, ischemia, they get a stress test just as normal, often those are treated conservatively just watching them. It's really the lefts being interarterial that are the most concerning by far. Okay? So it's important to know that distinction. Rights, even though they're both interarterial, the rights are much less likely to cause symptoms than the left-sided. Here's one example of a anomalous left coronary, which is coming from, actually originating together with the right, from the right sinus Valsalva, and it comes in that interarterial course. And to make things even more confusing, there's a couple variants of the left, which are also important to know because one is associated with a high risk of sudden death and the other is not actually. And what you can also see is that this tends to, as it runs over towards the left side, it actually runs within the muscle of the septum. And this variant is called the transeptal type. And the transeptal type also is probably not a clinically significant lesion, even though it runs between the aorta and the right ventricular outflow tract. This is distinguished when the left is anomalous, the difference between the transeptal and the interarterial. Transeptal kind of, if you look on coronal images, it kind of swoops downwards, inferior, into the septum, and then comes back up into the atrioventricular groove. Whereas the interarterial usually just goes straight across without making that downward swoop into the septum. This will be surrounded by the septal myocardium. This is not surrounded by the septal myocardium. This one tends to have a nice big wide open ostium. The ones that we worry about are the ones that have these sort of narrowed ostium because they travel in the wall. Often they have a very slit-like orifice, that's what people always talk about, and they have a very oblique shape to them, not round. Okay, so also very important to know these two types. Transeptal, not usually associated with sudden death. Interarterial, much higher risk. And here's another example of the transeptal. Here on the coronal, you can see it nicely, how it kind of swoops downwards. If it was interarterial, it just goes straight across. This kind of swoops downwards, extends into the septum, and is surrounded by muscle all the way around. A couple little interesting coronary anomalies or abnormalities that you may see in your practice occasionally, and it's good to know about them. Here's a patient who's like, you look at the scan, you're like, these coronary arteries are enormous. And what do we think about when we see enormous coronary arteries? I mean, you know, vasculitis is probably right at the top of the list, connective tissue diseases, Kawasaki's in a young patient in particular, things like that. And when you look at there's the origin of the right coronary artery. And actually, when you look at the origin of the left, you realize that it's coming off the pulmonary artery, which is not normal. And this is a case of what we call anomalous origin of the left coronary artery from the pulmonary artery. And we've seen a decent number of these. Not a common abnormality. We've seen a decent number of these. Usually presents in young patients, but we've had a few that presented in older patients because they were well compensated. Here are some of the other things that I think about when I see really big dilated coronary arteries. Again, vasculitis, connective tissue disease. Fistulas tend to be one vessel, not diffuse. And then Al-Kappa is usually diffuse because eventually the right is high pressure, high oxygen. The left is low pressure, low oxygen. Eventually these develop collaterals between the two and the flow starts to reverse in the left and starts to flow from the left coronary artery into the pulmonary artery. That's not good. Okay, here's just a volume rendered image showing you the normal origin of the right and the left that's sort of coming off the side of the pulmonary artery. So something that you may see, something you should be aware of. All right, great. One other thing that you might see, particularly as a complication of cardiac catheterization, is this. We see a left LAD, I guess, that's really dilated here. And we also see there's a little linear filling defect in the left anterior descending coronary artery. So this is a patient who's post-cath. This is a coronary artery dissection, which is often post-procedural, but also may be seen as a without the history procedure and often is seen in women who are peripartum. Here is the curved multiplanar reformat just showing you that dissection there. And this is some information on dissection, most commonly post-procedural, but the other situation in which patients are high risk are women particularly who are peripartum. And it does also have association with FMD in other locations like the renal arteries and things like that. Okay, and now we're going to finish our whirlwind tour on pulmonary embolism imaging. I'm trying to make imaging of pulmonary embolism, which we do every day. I'm going to try to emphasize a few of the controversies and kind of what your approach should be and how you should read these. Unfortunately, radiologists do not have a very high interobserver variability for small vessels. So I'm going to try to hopefully get everyone on the same page as to how we read them, and then you can make up your decision on how you read them as well. These are the three classic appearances of acute PE. Central filling defect surrounded by contrast, eccentric defect that's touching the wall, but where it touches the wall, it has acute angles with the wall, and then abrupt occlusions, which are perhaps the most challenging to see, particularly when you're seeing them in small vessels and just looking at axial images where you see, oh, there's contrast, next cut contrast, next cut no contrast. A little bit hard to appreciate that in some cases. Classic acute PE imaging. Now, as I said, we don't necessarily agree on the cases of small PEs. And the worst thing that you want to do as a radiologist is overcall PE. We'll talk a little bit about the significance of small PEs in a second. It's probably a single small PE is probably not clinically significant. I'm a radiologist. My favorite plant is the hedge, so I'm going to throw in probably there, but because that's what I do. But anyway, probably is not clinically significant. So you want to maximize your detection of clinically significant PEs, but minimize your detection of clinically insignificant PEs, which are small. And we know we don't agree on very much. So the goal is to maintain specificity. And these are our criteria for calling a QP. Must meet all these criteria. PEs are like worm-shaped. So you must see them, if you're seeing the vessel in cross-section, you have to see it on at least 2 or 3 images in a row. If you see it only on 1 image, it's probably not a PE, okay? It looks elongated, longer than it is wide. It's low density. A lot of these artifacts, like heterogeneous contrast mixing, things like that, will be in the range of 120, 130 Hounsfield units. This is thrombus. We know what density thrombus is, 30, 40, 50, 60 Hounsfield units. And then obviously, this is an obvious one, and I always put this up and people laugh, but I'll tell you, I've seen this mistake made where you have some filling defect and someone didn't go back and look that it's actually in a vein and not an artery. And these mixing artifacts are much more commonly seen in veins. So make sure it's in an artery. And then if the vessel's going this way, the PE's going this way. The PE's in a vessel. So the orientation, the direction of both of them are sort of in the same vector, like the same direction, all right? I think it's really helpful to toggle, when you see a potential defect, toggle between lung and mediastinal windows, because lung windows you can assess, is there motion artifact, is there respiratory artifact, a lot of other things is it mucus plugging? There's a lot of other artifacts which are much easier to see on the lung windows. Okay, so here was an acute PE. This patient has a central low density filling defect surrounded by contrast, looks dark, measured 40 Hounsfield units. We want to make sure we see it on at least 2 or 3 images in a row. Those are 3 consecutive images. There it is. It's in an artery. It's going the same direction as the artery. This is a PE. This was the only one. Again, probably not the best thing that we see this, but we have to report it. We're reporting the news here, but that's what it is, all right? Single small PE. What's the significance of single small PEs? I could do a whole lecture on that, but here's the highlights. This is a study looking at directly comparing single detector, and for all these, probably most people remember, I remember reading those single detector CTs, right? It took 40-second breath hold, or some crazy number like that. You'd start at the base to go to the apex. You wouldn't even include the whole lungs. You get 3 millimeter sections. Those look like total crap. These were hard to read, and you were missing PEs. So single detector versus multi-detector, beautiful state of the art. You see the small vessels, you see better with multi-detector. We know that already. Interestingly, the inter-observer agreement is a lot better for multi-detector, which is probably the main advantage of multi-detector is that we agree more on PE or not PE. Double the cases of a single small embolus on multi-detector. And that being said, the negative predictive value, so you take 100 patients who don't have PE and you follow them and see how many come back with symptoms of PE, the negative predictive value is exactly the same. So we're picking up a lot more small emboli, but they're probably not clinically significant. We missed them before. Clinically, in this case, it didn't matter. So this is my sort of plug for small PEs probably don't matter, so we shouldn't overcall them. So I recommend undercalling these maybe questionable small PEs. We usually just say positive, negative. There's not a lot of, there's a questionable defect in a single vessel, not sure, blah, blah, blah. Just yes or no. Our ER physicians love a binary decision, and we give them that. We don't usually hedge. We don't usually give these sort of questionable, blah, blah, blah. And if it's tough case, a lot of respiratory motion, bad bolus, I'll say, I feel comfortable to the segmental level or the subsegmental level. You give a sense of, sometimes they're mainly just worried about a big PE. And it's okay that the central and lobar vessels don't have any PEs in them. They're not clinically suspecting a small distal PE. Of course, there's lots of artifacts. I'm going to go through just a few. There's lots of artifacts that can mimic PE, which is why it's so important to maintain specificity and use these very strict rules about PE. And I'm just going to go through these, one each, okay? One artifact, we don't have enough time, but technical factors are a big one. Here's one example. This is a cancer staging case, and obviously We see a lot of incidental PEs on cancer staging cases in patients who have very few symptoms. There's this sort of abrupt cutoff in a vessel here. It was thought it could represent a PE, but we went back to the scanner. We did very thin reconstructions, and it looked beautiful. And this is just because the vessel is running a bit obliquely to the scan, right? This is sort of this part, which is well opacified, is in the middle of the scan. This is volume averaging with lung. Kind of looks like it could be a defect. Okay, what about flow artifacts are really common, probably one of the most common. This is commonly seen in patients who have lung disease where there's hypoxia, reflex vasoconstriction, and slow flow. And this is an example of a patient who has bronchiectasis, has this kind of wispy filling defect, doesn't look low density enough, has this weird sort of wispy shape to it, doesn't really look like thrombus, leading into that area. Did a repeat CT like 20 minutes later, a little bit delayed, goes away. All right, so this is just slow flow contrast mixing. Abnormalities adjacent to vessels, common mimic for PE. Here's one example. Patient has this sort of very central low density filling defect surrounded by contrast, looks like a PE, but then we see other things that look very similar in places where there are no pulmonary arteries. And this turns out to be a case of a patient with renal cell carcinoma. And what you're seeing is a big node that's in the hilum between the truncus anterior, which runs up, and the interlobar, which runs down, okay? Lymph nodes, mucus plugging is another common example of something adjacent to the arteries that can mimic PE, okay? And then the last category is things are actually inside the vessels themselves, but aren't actually thrombus, such as tumor or infection. Here's an example of a patient with colon cancer, has this central low density filling defect in an artery, but it is very hyperexpanded. This marked hyperexpansion is actually a good sign. When you're wondering about a defect and the vessel is enlarged focally at that area, it usually is real. It's a confirmation it's real. But when it's really big, you tend to think of other things besides bland thrombus, and we mainly think about infection, like fungal embolism, septic embolism, things like that, and tumor. And this patient had a history of colon cancer. So this is actually an example of intravascular metastases where the metastasis is embolizing to the lumen of the vessel and growing within the lumen, not so much invading outside. Couple last points in the last minute or so. CT is really good for acute P. It's probably the best imaging test for acute P. Probably even better than angio. It's not very good for chronic PE. And because the findings are very, very subtle. VQ scan has been shown to be superior in at least one study. You can see the sensitivity of CT is low, VQ is very high. And the reason for that is because, well, these are the classic signs of chronic PE, and we usually don't see these. Eccentric defects that have obtuse angles, areas of wall thickening, little webs, these linear defects in the arteries. But we see these in a minority of patients with chronic PE. These would be easy to pick up if that was the only finding we saw, the main finding we saw. Usually we see this, and this is really subtle. These are two adjacent images in the patient with chronic pulmonary arterial hypertension. We see I think actually these are 0.625 millimeter images. So within half a millimeter or a little bit more, that vessel, which the aerial on, goes from being large to being super small. This very rapid tapering of vessels in the mid-lung is a sign that you should look for very closely for chronic PE. But it is super subtle to pick up. Here's an example. Rule number 3 in radiology, the hardest things to see are those that are not there. And we miss this entirely. That's the right upper lobe pulmonary artery. Totally gone. We totally missed this. VQ scan showed a big defect up there. Very easy to see. And this just shows you why VQ scan can be more sensitive than CT in evaluating chronic PE.